Okay, I think we can go ahead and get started. Um, Welcome again. My name is Leslie Ritter. I am a member of the ABC's Board of Directors and currently serve as Advocacy Chair for the ABC's Advocacy Committee. I am the Vice President of Healthcare Access at the National MS Society. Um, Thank you for joining us for this afternoon's educational webinar and our deep dive into CMS. As you know, these webinars are driven by members of ABC having questions around the regulatory process. We started these last year and are excited to continue them into this year. Um, so I will kind of set the stage. I know many of us in the patient community have long known of CMS as role in access and access for our populations, but it's increasingly become more into the forefront in the past couple of years, just how integral that role is with new products coming to market in the neuro and brain disease space. So to kind of help us into this conversation, I wanted to introduce Erica Miller, who's a partner at CRD Associates. She has nearly 2 decades of experience in health policy and advocacy. CRD Associates has been ABC's legislative consulting firm since ABC was founded in 2004, I think. So Erica has intense expertise in this area, navigating the regulatory system and the process. And so she is an ideal candidate for leading this webinar today. I will turn it over to Erica in just a moment, but just wanted to remind you, um, so we will have opportunity for Q&A at the end of the webinar today. So if you have something that's top of mind, burning question, please feel free to drop it in the Q&A button down at the bottom of your screen at any time during the conversation, and we will get to that at the end of the presentation. So Erica, thank you so much for joining us, and I'll turn it over to you.
Thanks so much, Leslie. It's great to be here today and going to talk to all of you about just providing an overview of CMS, the different programs that are within the jurisdiction, its role in payment and coverage. We'll talk about Medicare, Medicaid, its role in the ACA exchanges, the Innovation Center, some rulemaking topics and the timeline of when typical rules come out, and just how to engage with the agency, since it is, I think, sometimes a little daunting for people given the scope of the agency and what they cover. So just for those of us who've been around for a while, sometimes you hear CMS as the agency that was previously referred to as the Healthcare Financing Administration. It's been CMS for a while, but sometimes you'll see it in reports and legislation when it was HCFA. And as I mentioned, it does administer the Medicare program. I think sometimes we forget that CMS is really just a big insurance company, but they have full responsibility over the Medicare program. They work with state governments to administer Medicaid and CHIP, and then they also have a role in HIPAA standards as well. Since the Affordable Care Act was implemented, they administer the marketplaces. And then also tying back to the ACA, they test new payment models through the Innovation Center. And we'll talk about all of this in more detail. But just to give you a sense of the agency, this is their org chart. As you'll see, it's quite large. And again, this is a really large organization that is not only an insurance company and access from that side for beneficiaries for Medicare, but also doing a lot on the policy side. We're not even going to spend time talking about fraud, waste, and abuse and what they do on that side as well. But you can see that this is a large organization with many different areas within its jurisdiction. So we're going to start with Medicare. And I think this graphic on the slide is actually CMS's graphic. But I do think it's important we think of Medicare as insurance for individuals 65 years or older. I think it's also really important to recognize that certain people with disabilities are also covered by Medicare, as well as patients with end-stage renal disease. End-stage renal disease is the only condition that automatically qualifies a patient for Medicare. So obviously, patients 65 and older is the largest population of Medicare beneficiaries, but there are also people under 65, either those with a disability or ESRD. The most recent statistics show that there are over 65 million beneficiaries enrolled in Medicare. So again, thinking about this as a huge insurance company. And then ultimately, the providers who engage with CMS through the Medicare program, over 6,000 hospitals, over 15,000 skilled nursing facilities, and over 1.4 million physicians and other providers. So a huge program, both in terms just administering coverage and benefits for individuals and processing claims, but then also setting policy for all the different facets of the Medicare program, which we'll run through also on this slide. So I think it's helpful just a refresher of the ABCs of Medicare. So Part A is the hospital inpatient benefit. It also includes skilled nursing facilities, hospice, and some home health services. Part B is for beneficiaries when they are going to their doctor's office. So it's physician services, other outpatient care. So outpatient hospital services, durable medical equipment, any DME, also some home health services and preventive services all fall under Part B. Part C is typically referred to as Medicare Advantage, which is Medicare approved private insurance plans. They provide all Part A services and Part B services and may provide prescription drug coverage and other supplemental benefits. We'll talk more about Medicare Advantage compared to traditional Medicare, particularly since Medicare Advantage is growing in its coverage of the Medicare beneficiary population. And then the newest benefit to Medicare is Part D, the prescription drug benefit. This was authorized back in 2003. And so how it works is beneficiaries, typically those who are, not in traditional Medicare, not in Medicare Advantage, are able to purchase Medicare approved private insurance plans that provide outpatient prescription drug coverage. And again, this is the newest benefit to the Medicare population or Medicare program. And that was authorized back in 2003. So let's quickly talk about how the different pieces of Medicare are funded. So Part A, so again, that's the hospital benefit, are funded through payroll taxes. When you see on your pay stub that there's Medicare withholding, this is what funds Part A. Parts B and D are financed through income taxes, but those go into the Treasury's general fund and are not in the hospital insurance trust fund. Keep that in mind. That's going to come in to play in the next slide. But these two also, besides coming out of being funded through the general fund, parts B and D also have premiums associated with them for beneficiaries. So again, if you want coverage to go see your doctor in their office, or you want that prescription drug coverage, you typically have to pay a premium for that plan. Part C is funded through the same taxes and premiums as parts A, B, and D. And in some cases, beneficiaries have to pay a separate premium to enroll in Medicare Advantage as well. So we all hear about Medicare potentially running out of money. And I wanted to pull this graphic that came from the Kaiser Family Foundation. And you'll see, we're now in 2004, that the trust fund is still predicted to be solvent. And I do want to stress, I mentioned that Part A is what is funded through the Medicare Hospital Insurance Trust Fund. That is the only part when they're talking about insolvency that they're talking about. They're talking about that Part A coverage, since parts B and D are paid for and funded separately. It's hard to predict Medicare solvency in the long term because so much of this has to do with the worker to beneficiary ratio. Again, as I mentioned, when you look at your pay stub and you see the Medicare withholding, that is to fund the hospital insurance trust fund. So as the population ages and they age into Medicare and there are fewer people working, that has a big impact on solvency. But I think as we think about potential Medicare Part A insolvency, and you look down the road here, some budget experts have said that even if Medicare was insolvent, they would still be able to pay out 89% of benefits just based on what's coming in through payroll taxes. But again, when we think about Medicare and we think about Medicare spending, this is why there's so much talk about what can we do to kind of control costs in Medicare while improving quality. It's because ultimately we recognize that the receipts for the hospital insurance trust fund that funds Part A are not going to be keeping up with the benefits that are being paid out in the not so distant future. I also wanted to talk a little bit about Medicare Advantage and traditional Medicare enrollment. As you will see here, 2024, there are now more, so we're just about kind of the 50-50 split of having patients in Medicare Advantage and traditional Medicare. And we'll talk about the two different programs, but I think that this is really important. If you're like me, when it comes time for Medicare enrollment, you're maybe bombarded with watching advertisements on TV for different Medicare Advantage plans, those private plans in Medicare. And so, that's something that is growing in popularity. And as you'll see, according to this Kaiser Family Foundation chart, is predicted to continue to grow in popularity. One thing that I think is important, and as we move into the next slide, what we do see with Medicare, traditional Medicare versus Medicare Advantage, is that as patients get older and sicker, if they were in Medicare Advantage, they might move over to traditional Medicare. And that is probably because it's easier to access your benefits in some ways for traditional Medicare. You'll see that in traditional Medicare, all doctors and hospitals that take Medicare are covered, as opposed to Medicare Advantage, where the doctors and hospitals and other providers have to be in the plan's network. Under traditional Medicare, referrals are traditionally not required to see a specialist, but you may have to in Medicare Advantage. And I think we all know how frustrating it is to have to see your primary care doctor, get the referral to see a specialist, particularly when you might be older and have to see a lot of specialists. That's a lot of back and forth to doctors. In traditional Medicare, there is a 20% coinsurance requirement, but you can purchase Medigap coverage to cover these costs. In Medicare Advantage, those out-of-pocket costs might vary. You don't know that it's always a 20% requirement. Sometimes actually everything might be covered. Other times you might have more than a 20% responsibility and you don't have the option to purchase Medigap to kind of make up that shortfall. There's no annual out-of-pocket limit in traditional Medicare. Out-of-pocket costs are capped in Medicare Advantage. And I think this bullet is why sometimes Medicare Advantage seems so attractive to some. Vision, dental, and hearing services are covered in Medicare Advantage, while they're not covered under traditional Medicare. Part D, as I mentioned before, you have to purchase a separate prescription drug plan, while drug coverage is included in most Medicare Advantage plans. So I think what happens is ultimately you might see beneficiaries enroll in Medicare Advantage, thinking that premium that they might have to pay for their Medicare Advantage plan covers everything. But as they kind of go down the road, they see that maybe not everything is covered. And there are some kind of gatekeeping requirements. And there are also more prior authorization and utilization management requirements in Medicare Advantage versus traditional Medicare. Some of you might have been aware of the rule that was recently finalized that was making some changes to prior authorization and utilization management in Medicare Advantage that will take effect in several years. I'm going to talk a little bit about each different part of the Medicare system. So Part A, as I mentioned, is the hospital benefit. What it covers is 90 days of care per episode of each illness. And I will say that there is a reserve of covered days should you need more than 90 days of care per episode. I do want to say that payment is made for every inpatient stay or discharge. So when we think about kind of a bundled payment or an episode of care, that is how Medicare Part A operates. And those episodes of care are all grouped together in the MSDRG system. So you might hear that referenced, but basically there are DRGs for all of the different potential reasons that you might be admitted. And then all of the rules around Part A are updated annually through the inpatient prospective payment system rulemaking. and we usually see that proposed rule in August. I will say that the policies and payment are set for Part A on a fiscal year as opposed to a calendar year like other parts of Medicare. Um, so this slide might make your head hurt, but we don't have to spend a lot of time here, but I just do want to highlight that, we are looking at an MSDRG for payment, but these MSDRGs are weighted, and then they are also adjusted for geographic different variations. There are also adjusted payments if a hospital is participating in the graduate medical education training program. There are also ways to cover additional costs if a service is available for an outlier payment. And I also just want to note that the payments in the inpatient system are updated with an inflationary update annually. But so this is a complicated system, and we could probably spend a whole hour talking about DRGs and cost reporting and how individual payments for different episodes of care are set. But this is kind of a really high level overview of what that looks like. So again, you've got the DRG for the service, you've got adjustments for geographical factors. You have adjustments if you are potentially an high cost outlier, and then there are adjustments if you're at a training hospital, et cetera. Moving into Part B, again, Part B, this is the part of Medicare that covers outpatient hospital services and physician offices. So I think it's really important to think about, an inpatient is when you're admitted. Outpatient is when you don't qualify for an admission, so you're not in the hospital long enough. Think about observation services, emergency room services, outpatient clinic services. I think for this group, also thinking about potential mental health services are covered under the outpatient prospective payment system, certain Part B drugs, certain medical supplies. And again, physician services are a lot more straightforward. It's the care that's delivered in a physician office setting. But these are two different payment systems. Looking at the outpatient prospective payment system, again, just a high level look at all of the different factors that go into that payment. Like the DRGs, what the outpatient system uses is an ambulatory payment classification. And so each APC has a number of CPT codes in, all of them that make up the care that you might receive in that APC. Again, these are adjusted for geographic factors, for the complexity of the service, and there is also an outlier. And like the inpatient system, their conversion factor is also updated for inflation. This is an annual rulemaking that is done on a calendar year cycle. The outpatient prospective payment system proposed rule is usually released around July 4th. So those of us who spend a lot of time playing in the regulatory space don't make any July 4th plans that take us very far away from our computers, since usually we not only get the outpatient rule as a gift, but we also get the Medicare physician fee schedule that's released around the same time. There are about just under 13,000 individual services on the fee schedule. They are all valued relative to one another. And so there are three different components of that valuation. There is the physician work. There is the practice expense. So when you go to the doctor, practice expense accounts for what they pay for rent for their office. If they draw your blood and they use a needle and then put a Band-Aid on, the needle and the Band-Aid and the gauze are all part of that practice expense. The rubber gloves that they wear all goes into that practice expense bucket. And then this MP is malpractice. So every different specialty has different kind of malpractice coverage. And so that's accounted for. All of these are adjusted geographically. That GPCI is a geographic practice cost index. So again, all updated based on where you are in the country. And then it's multiplied by a conversion factor, which is set annually in the physician fee schedule rule. This conversion factor is not updated for inflation. So those of you who are hearing every year about needing a doctor's pay fix, it's because that conversion factor is actually eroding in value. But then that's how you set the payment. And just to kind of go into the conversion factor, this is one of my favorite charts that I have stolen from the AMA. You can see basically over the past 2 decades, physician payment under Medicare has essentially stagnated, while you see that the inpatient hospital, skilled nursing facilities, the outpatient hospitals have all kind of gradually increased, and that's with inflation kind of moving along at a similar trajectory to consumer prices. And then also you'll see the increase for the practice cost inflation, or MEI, that's the Medicare Economic Index. So physician payment, which doesn't just cover payment for physicians, but covers paying for all the office staff and the actual office itself, that payment has been stagnant. And that's why you might hear about the need for a physician pay fix by Congress each year. I do want to talk a little bit about talking about Medicare coverage, because Medicare coverage applies between the different services. What you have covered in Part B and A will also be covered in Part C if you're a Medicare Advantage. So the standard for coverage is reasonable and necessary. Is the service deemed to be reasonable and necessary in the Medicare population? And I think this is an important point, because when CMS is thinking about coverage in the Medicare population, even though I mentioned that there is coverage for those under 65, for those who might be disabled or have end-stage renal disease, they are really looking about reasonable and necessary in that 65 and older population. And you'll see just the graphic was a tracking sheet for a national coverage determination that applied in the brain health space. And so I just thought that would be a good graphic to share. Ultimately, this is something that didn't go forward, but CMS develops national coverage determinations, and that coverage is administered by the CMS Coverage and Analysis Group, or CAG. And I have to tell you that national coverage, as the name implies, applies nationally, or doesn't matter what region you might be in. Those are national coverage standards that are available for all Medicare beneficiaries. There are also local coverage determinations. So if there's no national coverage determination for something, then that means that coverage is determined on the local level. There are 12 Medicare administrative contractors who develop local coverage determinations. And even if there's not an LCD, a local coverage determination, then coverage is determined on a case-by-case basis by the MACs. So you've got the national coverage determinations, which again apply across the whole country. There's currently a backlog for developing national coverage determinations. CMS has recently started updating a wait list related to national coverage. The local coverage process moves a little bit more quickly. And I think it's really interesting, if you kind of dive deep into coverage, you'll learn that there might be one MAC who specializes in coverage for laboratory services, as an example. And then some of the other MACs kind of piggyback off of the work that they do. There might be another MAC that is leading on durable medical equipment, and then other MACs tend to follow. So, but they don't have to, and you do see some variation. This again, these local coverage determinations are determined by the MACs on a regional basis. And as I mentioned, there are 12 different Medicare administrative contractors, or MACs. Quickly into Part D, I mentioned that this was the newest benefit, authorized in 2003 and effective and available to beneficiaries January 1st, 2006. Unlike Part A and Part B, this is a voluntary benefit. Again, like Part B, you have to pay a premium to get prescription drug coverage, the same way you pay a premium for Part B to get your physician office coverage. In 2023, there were more than 50 million people enrolled in a Part D plan. So I mentioned that there were over 62 million enrolled in Medicare. So the vast majority take advantage of this benefit. As I mentioned earlier, private plans offer coverage and beneficiaries get to choose between those plans. There is a standard benefit package that is specified that ultimately all plans have to offer. But I will say that all of the formularies differ by plan. And so for those of you who might have a Medicare beneficiary in your life, a parent or another relative, I know that I spend time each year going through the different formularies with my mother, so she can find the package that covers the plan that covers most of the drugs that she has to have. Again, there's a monthly premium, there's a cap deductible, and there are co-payments for drug purchases. Um, the donut hole, which was established when the benefit was established, once you hit a certain threshold of benefits until you got to catastrophic coverage, you were in the donut hole. That is closing. And so patients will have less out-of-pocket costs, and those costs are actually going to be capped as of next year. They're going to be capped at $2,000. I think they're capped at 20. I'm going to get the number wrong. They're also capped this year as well at a higher number. But next year, there will also be an option to pay your out-of-pocket costs in installments over the course of the year, which for Medicare beneficiaries who might be on fixed incomes will allow them to better control their cash flow. This opportunity to pay for costs over the course of the year works better if you have a high kind of copay early in the year, up to $2,000. So you can then spread out over the course of the year. But that's coming next year, and I think will be really helpful for beneficiaries who are trying to stay within their budgets. Switching gears for Medicaid, do you want to talk a little bit about what this program looks like? Again, besides Medicare, some people with disabilities are on Medicaid. It is available for some elderly individuals, and you do have beneficiaries who are dual eligibles for Medicare and Medicaid. Pregnant women are eligible for Medicaid, as are all children, and then low income adults, which is related to the expansion under the Affordable Care Act. And so we've got more than 72 million people enrolled in Medicaid. And for children, just under 40 million children are enrolled in Medicaid and CHIP. So again, all children fall into the Medicaid bucket. Low income adults fall into the Medicaid bucket, as well as pregnant women. So Medicaid is a network of state programs. Each state administers their own program. CMS sets the broad guidelines for those programs that are governed by statute, regulations, and other policies. But each state gets to determine its individual eligibility standards, the type, amount, duration, and scope of services, the payment rates. I will say if there are utilization management or prior authorization requirements, they are set at the state level, not the federal level. And certain groups of Medicaid beneficiaries will pay enrollment fees, premiums, deductibles, or copays. But a lot of this is very much income-based. I just want to give us a sense. I feel like for a long time, people talk about Medicaid and Medicaid expansion under the Affordable Care Act. At this point, Medicaid has been expanded in 40 states and the District of Columbia for adults under 65 with incomes at or below 133% of the federal poverty level. This was not available before the ACA, and I think those of us who have been advocates in this space know that it has taken some time to get Medicaid expanded in 40 states. They also aligned the eligibility threshold for Medicaid for children at that 133% of the federal poverty level. So we can see how far Medicaid coverage has come for low income adults. Also want to talk a little bit about Medicaid waivers, and you might hear about waivers a lot. Basically, a state could apply for a waiver to have different additional flexibility in how they design their Medicaid programs or to waive certain statutory requirements. And I think the waivers that we hear about the most are Section 1115 waivers, and these are for research and development. Um, States can apply for these waivers to run a pilot or a demonstration project. It has to be budget neutral. They are approved by CMS for 5 years. They can be reapproved for an additional 5 years. But when you think about state waivers in this bucket, they look at expanding eligibility, expanding benefits, and ways to address social determinants of health in their state programs. The other bucket of waivers is Section 1915 program waivers. These you don't hear about as much, and they are really looking at how to address home and community-based services and waive some of the Medicaid requirements to expand access for those services. And just the last bullet here, there's a searchable list of all the approved waivers by state. So if you're interested, you can go to CMS's website and look at the different waivers that have been approved under both different waiver authority, the 1115 and the 1915, and you can see which states have gone down this route and what they've done. Just quickly about the Affordable Care Act exchanges. So for those who aren't eligible for Medicare or Medicaid, don't get insurance through their employers, and even some small employers buy insurance for their employees through the exchanges. These are administered by CMS. You probably hear in the fall about open enrollment, maybe see commercials about that as well. The ACA allowed states to maintain their own exchanges where residents of individual states could go to see the different insurance plans that are available in their state and purchase insurance that way. Ultimately, 29 states offer their plans through the federal exchange. 18 states and DC have state-based exchanges. And then there are 3 states who run their state-based exchanges through the federal platform. But that federal platform is run through CMS. There are standards for plans and enrollment that are set through CMS rulemaking, also known as the Notice of Benefit and Payment Parameters. And that's another annual rule that CMS puts out related to these ACA plans. On the Innovation Center, do want to talk about this a little bit because we've heard about it a lot since the passage of the ACA when it was authorized. $20 billion in funding has been awarded to the Innovation Center to date. Another $10 billion is going to go to the Innovation Center in 2030. So this is not subject to the annual appropriations process. And the Innovation Center's goal is to improve quality and reduce costs across CMS programs. What they are doing is testing new payment and service delivery models. They may do it in conjunction with the private sector, and you might see kind of private public payer partnerships in Innovation Center models. I just highlighted a few models that are either being developed or being tested by the Innovation Center. The Accountable Care Organization REACH program. So accountable care organizations have been around for over a decade now. And this is the latest iteration of the Accountable Care Organization program, the REACH program, and it's targeted to address underserved populations, social determinants of health, and try and improve health equity. There's also a brand new cell and gene therapy access model that's launching in the Medicaid program. And this would basically allow states to opt in and, if certain standards were met, would provide financing for these expensive cell and gene therapies. There are also several models in the brain health space. So there's the GUIDE model that's focusing on an improved dementia experience, and then also a brand new model that's coming online, innovation in the behavioral health model. So I would maybe encourage all of you who are interested to go to the Innovation Center page. I highlighted 4 models, but there are dozens of models there. And ultimately, after the model ends, what happens is a report is developed and ultimately evaluated for what happens on the quality front and what's happened on the cost front as well. And then ultimately, some of these models could ultimately become permanent programs. I will say, I think that there are many in the community who've been disappointed with how few models are converted from kind of demos to permanent programs. But this is a way to test and provides funding for that testing of those models. So this is kind of a busy slide, but I did want to highlight kind of a rulemaking overview. Each January, I've talked a little bit about Medicare Advantage. We get a Medicare Advantage and Part D advance notice. That's actually open for comment right now, and the comment period is rapidly drawing to a close. In April, you get a final Medicare Advantage and Part D advance notice. That's usually when you get the inpatient proposed rule. You also get the final notice of benefit and payment parameters, which you'll see the proposed rule comes out in the fall. You get, if there's going to be any policy and technical changes to the Medicare Advantage program, that final rule comes out in the spring. Again, the proposed rule usually comes out in the fall. As I mentioned, the summer is a big time for proposed rules. You get the outpatient rule, you get the physician fee schedule proposed rule, and for those in the ESRD space, they have a separate payment system, and that rule comes out in the summer. You also, in the middle of the comment period for those three rules, you get the final inpatient rule because, as I mentioned, that's a fiscal year rule, not a calendar year rule. So it has to be implemented when the fiscal year starts on October 1. And then late October, November, you get the final rules from the summer, the outpatient rule, the physician fee schedule, the ESRD rule. This is when you get the proposed notice of payment, benefit and payment parameters and any technical changes to the Medicare program. So there are other rules that come out. Not every rule is an annual rule, but this is just kind of a snapshot of when some of the big annual rules come out. So there's a lot going on throughout the year. And I think this is really important as we think about influencing the agency. The best time to influence the agency is when they're developing the policy, so before it goes into a proposed rule. So let's just take the inpatient rule as an example. I mentioned that that comes out usually in proposed form in April. And so ultimately, the time to be talking to CMS about new policies that you would want to see in that rule is now. I put the physician fee schedule as an example here. Since that comes out in late June or early July, if you want to influence what goes into that proposed rule, you want to be talking to them, before the spring is over, because you want, your policies to go in proposed in the form that you would like to see. And I will note with the physician fee schedule, there are a number of deadlines in early February. If you want to have changes made to national coverage determinations, if you want to see some of those retired because they're old, you have to get that request in early February. If you want to add quality measures to the quality payment program that's in the physician fee schedule, you want to have those in to the agency by early February. If you think that one of the almost 13,000 services on the physician fee schedule is misvalued, and you think the value should be higher or lower, you want that into the agency by early February. So the goal is really to influence the policy as the agency develops it, rather than responding to something that's in a proposed rule. And just so you all can see, this is just an example of a Federal Register page with a proposed rule. And then you write your comments and they get submitted through regulation.gov. And that is the second box on the bottom that just shows what you do. You can link or you can attach your comments in a PDF form. And I just will say that when you provide public comment, it is in fact a public comment, and anyone can go to regulations.gov and search all of the comments that have been submitted. During the comment period, it is really the time to support or recommended changes to proposed policy. The comment period begins as soon as a rule is released. So I will just say I do a lot of work with the physician fee schedule that I mentioned comes out around July 4th. That proposed rule is over 1,000 pages. So you have 60 days to read that rule, digest that rule, and then write comments on it. So 60 days might seem like a long time, but you're getting a lot of content to evaluate and you have to turn it around quickly. When the agency or when a rule is open for comment, the agency is in listen only mode. So you could potentially meet with the agency and share what your concerns are, what you might be putting into comments. But the agency, CMS, will not be able to respond to you. And it's very typical to do meetings with CMS while they are in this listen only mode. But again, if you want to be able to go back and forth with the agency, you want to do that during the pre-rulemaking rulemaking period. So again, in your comments, you can support the rule, oppose the rule, recommend changes, and you can, submit comments on behalf of your organization. But you can also leverage your grassroots network to have different members, constituents submit similar comments to yours. It's also the time to potentially engage with Congress if you have any concerns about what's in the rule and want the agency to weigh in. Once the comment period closes, you've got CMS reviewing the comments that have been submitted. It's another opportunity to follow up with the agency on your comments. And then they develop the final rule that includes the policies that will be implemented. They respond to comments or just say, we got many comments that said XYZ, and we agree with you because of this reason, or we disagree with you for this reason. But there's, that's what we typically get in a final rule that is released with time for implementation. So again, I'll talk about the inpatient rule. We get that in early August because again, it gets implemented at the beginning of October, the start of the fiscal year. The outpatient rule, the physician fee schedule rule, those come out the end of October, beginning of November. Since those are on a calendar year cycle, and ultimately you have time for implementation. So that ends my presentation and happy to take questions.
Thank you, Erica. That was one of the best overviews of CMS because we could have been here for 3.5, 4 hours, and I feel like you hit every single part of that. But I have some questions that have come into me ahead of schedule. I do know I see a couple in the Q&A box. If you do have questions, it's not too late. Go ahead and jump them into the Q&A box. We'll try to get to as many as we can. One of the questions that I got beforehand, and I actually think it's a good one for many of us on the call, is what does patient engagement really look like with CMS? I know many of us are used to FDA where you have the Office of Patient Engagement, you have patient reps in the individual divisions, but what does patient engagement look like with CMS? Is there one entryway? What is the best way to find the people you're looking for at CMS?
So finding the people is hard, but I will tell you each rule that CMS puts out. So if you know what you're concerned about, like let's say Part B, physician services, go to the physician fee schedule rule. At the start of the rule, they list the staff and what they're responsible for in that rule. So that's a great tip in terms of trying to find the right people. If you are interested in coverage, I mentioned the national coverage determinations. If you go to the tracking sheets on the Medicare website, there's a Medicare coverage database. It says who the staff person is who's responsible for the coverage policy that's being developed. If it's a local coverage determination, which veering away from CMS Central and talking about the MACs, you can go to those MAC medical directors. So if you dig into rules, proposed or final, or any of these coverage documents, you are going to find the names. I will also just give you a tip for all of HHS. There is a website, an HHS staff directory with fillable fields. So if you know the name of the person because you pulled it from the rule, you pulled it from the coverage tracking sheet, you can find their email address and their phone number. Maybe not their phone number, but
Some things changed during COVID, but I think their email
Yeah,
address is still there.
I know their email address is still there.
Yeah, yeah. It's a I love that tip. Love that website. Um, so another question that came in is, what is the deal with the recent CMS guidance on Medicare Advantage coverage? It seems like MA companies don't like it, but what is new and what is the impact? Thanks.
So I'm not sure which guidance you're talking about, but I'm guessing maybe you're talking about what just came out about prior authorization, which was a huge change and will go into effect in a couple of years. And so, one, there are time requirements now for Medicare Advantage companies to respond to your doctor for prior authorization requests. It's 72 hours for an expedited request, and I believe it's 7 days for a regular request. I know 72 hours doesn't seem much like expediting anything, but that means that you, as a patient or a beneficiary, are ultimately going to get a response more quickly. There is also requirements for them to report out why things are not covered. So there's also information that has to be maintained in what they call application program interfaces or APIs. So those in the public can access information about what is covered. So these are a lot of requirements that are going to make it hopefully harder for coverage for certain services to be denied. And there will also be more information publicly available. So a lot more work on the Medicare Advantage companies part. I will note this rule does not apply to drugs, which is disappointing, but I know a number of groups commented that CMS should go back and look at some of these utilization management requirements as they relate to drugs.
That's great, Erica. Thanks. So I think another question is directly related to that around you mentioned how often CMS goes back and looks and kind of looks at rules or national coverage determinations, things like that. How long should the timeline be for groups who want either CMS to reevaluate something? When should they start approaching CMS? Um, and what is like a good expectation for groups to have there?
So I will give you guys an example from my own work. I mentioned end-stage renal disease because I work with the pediatric nephrology community. We started talking to them about in 2020 about how their payment rates don't cover kind of the unique costs and specialization that are required to treat children. We got something in the final rule in 2020, the 2024 final rule that went into effect of January 1st of this year, and so ultimately, it took us 3 years to get a policy change. Um, I will give you another example. Um, there was a national coverage determination that one of my clients didn't like for good reason. The coverage policy was last updated in the 80s. And so you can see how that would be a bit antiquated and it was limiting coverage. We had a conversation with CMS about it. They told us to apply for reconsideration, which is going through the coverage and analysis group. They realized that their policy was bad, that the coverage and analysis group was so backed up. There's another way to go through the physician fee schedule. Took 2 years through conversations with CMS and going through rulemaking. Remember, as I said, rulemaking is on an annual cycle, and there is kind of, you want to talk to the agency in the pre-rulemaking period in order to get what you want in the proposed rule. This is much easier to get a proposal finalized than to change something that the agency has proposed or get something added that wasn't in the proposed rule. So you have to kind of keep the rulemaking cycle in mind. Because if you have a great idea that goes into one of the calendar year rules, but you don't think about it until June, it's then you start talking to them for the rulemaking cycle for 2 years in advance. So it's a long slog.
Thanks for that. I think it's just helpful to set expectations, especially when you're talking about something that could have multi-year kind of implications. What in your experience has been, some of us who have Medicare beneficiaries in our patient populations, but also have people who live with disabilities who are in that kind of coverage area. What has been the most impactful information to share with CMS, specifically for populations that they're not maybe thinking of when you're looking at a typical Medicare population?
So Leslie, that is a great question, and I think this happens a lot. It's a big coverage issue, and I find it really frustrating because I have gone to CMS multiple times, and said, pregnant women is not your population. However, you have disabled women of childbearing age who are in your coverage population. But from the coverage side, they look at that very much for reasonable and necessary for someone 65 and older. And then they will basically say, there's the opportunity for Max to review on a case by case basis for those who are disabled. So I unfortunately don't have a really good answer for you, Leslie, other than to make sure that you're raising these situations and comment letters and in conversations with agency staff. But as they write kind of broad policy, they don't write these policies with beneficiaries under 65 in mind. And I wish I had, in preparation for this presentation, looked up kind of what percentage of the 62 million beneficiaries are under 65, but it is a really small sliver. And so when you think about CMS as a huge insurance company, from where they sit, that's not efficient, not helpful, but not efficient.
Right. Thanks. I think it's something that I think all of us are thinking about more and more when you're looking at ways to engage. Another question that came in, are MA plans under MAC decisions, or can they deny coverage for a service or procedure that the MACs cover?
So they are supposed to provide coverage for services that are deemed to be reasonable and necessary at a national level and a local level. So if there is a national or a local coverage determination, that applies in the jurisdiction that the plan operates, they are supposed to follow those determinations.
So another question that came in, how does CMS take quality of care into consideration when making payments or other policy decisions?
So Leslie, that's a great question, and we probably could have spent several more hours together talking about this. I will note that all of the Medicare payment systems all have quality reporting programs that are included in those payment systems. So I'll just take the physician fee schedule as an example because it is the program that I work with the most. There is a program called the Quality Payment Program is included. Every provider in the Medicare Part B space has to report certain quality data to the agency, either through a program called the Merit-Based Incentive Payment System or through an advanced alternative payment model like those that are being developed by the Innovation Center. So I think it's, every rulemaking covers these quality payment programs. I will say under the Biden administration, they are looking to expand reporting related to social determinants of health and looking at those programs as a way to improve health equity. But it is different in each different facet of the Medicare programs.
And just to kind of go back to our previous question, Anita put in the Q&A box that it's 7.7 million people under age 65 with disabilities. So that's about 12% of all Medicare beneficiaries. So I love these webinars because you can tell where the health policy wonks really are. Um, we had another question that came in. You mentioned a way to find a person at CMS involved with a specific coverage determination by looking for their name and email. If I'd like to ask them about coverage considerations for a different therapy in that same space, could I just reach out to them and ask the question? Would they be receptive to that?
Absolutely. I think you'll be surprised at how receptive some of the career staff are at CMS. So if you can track down the right person, they will give you an answer, maybe not right away, but might have to look into it and get back to you. But I definitely encourage you to reach out. And again, you can use that HHS search tool. But again, the coverage and analysis group has all their different tracking sheets, and you can see who's kind of working on coverage in that area. And if they're not the right person, I find that people are really helpful and refer you to the people who are.
Yep, I think once you get an email into the agency, it bounces around a little bit, but eventually does land where with the person who's in charge of that issue. Um, so I think we have time for a couple more questions. Um, okay, yeah, I think this is a great one for those of us on the call. What is CMS's role in implementing healthcare reform initiatives and addressing the evolving needs of Medicare and Medicaid beneficiaries? Because we know that Medicare beneficiaries today don't look like what they did 20 years ago.
So I think that's a great question. And like all federal agencies, CMS does have to work within its statutory authority. So have to think about what is covered by statute. I'll give you a good example though of how the agency's kind of thinking could change. I know since COVID, all of us are really interested in telehealth services, and making sure that patients still have access to virtual care in their homes when it's appropriate. So after the end of this year, CMS won't have authority to allow care to be delivered to beneficiaries in their homes. That requires Congress to step in. But before COVID, they paid for these services at a rate lower than a face-to-face service. And through rulemaking, they do have the authority under the statute to set payment rates. They changed it so now there's parity between in-person and virtual care, and they were able to make that change through rulemaking. So it all depends on what their statutory authority is. Like, for instance, we talked about Part D. There was no authority to cover prescription drugs until 2003. So had to wait for that change to occur. But if there are ways, and I think the agency is looking at, you know, they've looked at hospital readmissions and how to try and control costs and reduce readmissions. Like that's something that they have been able to do, on their own. So, yeah.
It's really important for those of us on the call who care about telehealth and its future. Um, I think one question that we hear a lot of times is around Medicare reimbursement. And what is the best way, from your experience, to talk about reimbursement issues as a patient access issue? Because I think it's often kind of thought about as a very financial give and take. I do think that like thinking about CMS as a big giant insurer is like a really good way to look at it. But what is the best way that you found for patients to talk about reimbursement in a way that kind of highlights the access issues that it does bring upon patients?
Well, and I think that's just it. Access is the way to do it. And I know if you look at certain parts of the country, you might not have access to neurologists. And so, why is that? Because it's not profitable to maintain a practice. And I could go back to my favorite chart that has shown, what has happened with physician payment over the last 2 decades. And I think it's a little bit of a misnomer to say physician payment, since it not only covers the payment for physicians, but it also covers the patient or the reimbursement and salaries of office staff and any nurses on staff, et cetera. But I think that access is we see kind of a move to consolidation. You see those individual practices close, you see longer wait times.
Mhm.
So I think particularly talking about how far you might have to travel now because you don't have access to a specialist in your area, how long you have to wait to get an appointment with that specialist. Those are all really important things to flag when you're talking about reimbursement because reimbursement is driving access. And I have heard different physician specialty groups say that they have stopped taking new Medicare beneficiaries because of reimbursement rates. It just
Yeah,
doesn't. They can't sustain their practices on those
right.
payment levels.
Yep. Well, I think I got to all the questions in the queue box that had came my way. If there are additional questions, Erica, would you be open if people want to email Katie or I and ask questions behind the scenes?
Sure.
That would be great. Thank you so much. Thank you everyone for attending this afternoon. A special thank you to the ABC Advocacy Committee and to the program committee who come up with the ideas for these webinars and this educational series. Again, thank you to Erica for your brain trust and sharing of ideas and your knowledge today. And we will see you on the next webinar.